Ifosfamide and cyclophosphamide are very similar in their structure, but it should be noted that the dosing is very different. So ifosfamide dosing, because of its slow uptake, is generally 4 times greater than that of cyclophosphamide.
There are going to definitely be a lot of considerations that nurses have to think about with patient management.
Right, not just the ifosfamide, but have to consider the other drugs as well in the regimens. I cannot stress enough the importance of hydration. So we're going to teach patients hydrate, and even if you think you've hydrated enough, hydrate some more.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Rebekah Flynn, Associate Director of Quality Improvement and Education at Washington University Siteman Cancer Center in St. Louis, Missouri, and Board President of the St. Louis ONS Chapter, to discuss how to safely administer ifosfamide chemotherapy infusions. This episode is part of an ongoing series about outpatient oncology drug infusion. The others are linked in our episode notes. Thanks for joining me today, Rebekah.
Thank you.
So to start us off, can you give us some background on ifosfamide?
Sure. Ifosfamide was developed by a German company that also developed another cancer drug we're familiar with, cyclophosphamide. This drug was based on the knowledge that there's a particular enzyme, phosphoamidase, that tends to be overexpressed in solid tumors. Their intent was to find a substrate of this enzyme that would be inactive and non-toxic until it reached the body where it's activated. This drug's been around for a long time. The first mentions of it in human studies appeared in the literature in the early 1970s. And it received FDA approval for a third-line treatment for testicular cancer in 1988. There are many off-label uses for ifosfamide that we're going to talk about later on that are used as part of treatment regimens.
So what is the mechanism of action for this drug?
Ifosfamide is an alkylating agent which keeps cells from reproducing. It is cell cycle non-specific, so it has action in all parts throughout the cell cycle. As an alkylating agent, it is bioactivated by the P450 enzymes in the liver, which sort of flips a switch to activate the metabolites. There are 2 metabolites in particular, phosphoramide mustard and acrolein. Activated metabolites do 2 specific things. First, they bind to the DNA that causes damages or breaks in the DNA strand, which will eventually lead to the second thing, which causes apoptosis or death of the damaged cell. Once the drug has done its job, it's excreted through the kidneys.
That was a great explanation of it. Now I want to talk about a little bit as far as the diagnosis that our patients might have that this treatment would be used for. Can you talk about what cancers and diagnoses that happens with?
Sure. As I mentioned, ifosfamide is FDA approved for testicular cancer. That's actually the only FDA approval, but there are many off-label uses where ifosfamide is used as part of a regimen. And some common diagnoses are soft tissue sarcoma and Ewing sarcoma, as well as osteosarcoma. GYN cancers, specifically ovarian and cervical. Ifosfamide is also used in bladder cancers, both small and non-small cell lung cancers, as well as non-Hodgkin and Hodgkin lymphomas.
That's a lot that can be used in, especially kind of outside, like you said, off-label use with some of those other regimens. Yeah, so are there any contraindications to using ifosfamide?
There are not many, but the ones that do exist are very important. First of all, if the patient has ever had a known hypersensitivity to the drug or to any of its components, it would not be indicated for use. Because of some of the side effects of ifosfamide, if the patient has any type of urinary tract obstruction, it can allow toxins to accumulate and cause some issues. Because the way ifosfamide is metabolized and excreted, if there is renal or hepatic impairment, it requires a second look, and if it's severe enough, this may not be the right drug to use. And the final contraindication would be hematologic effects, thrombocytopenia and leukopenia, because again, the patient can develop some toxic hematologic effects.
Well, those are really important things to make sure of whenever you have a patient who is going to be getting that treatment. And especially when you know that they've had a reaction. And, with patients traveling between institutions and also across state lines and things like that, it's so important that the patients know that so that they can, transfer that information if they would be going to a new center for treatment or something like that.
Absolutely.
So now talking about oncology nurses, I've got a couple of questions about that. What do they need to know about administering ifosfamide? And because it is on the NIOSH list as a hazardous drug, is there any specialized training that nurses need to know or do for administration or precautions that they must take? I know that's a lot of questions, but...
We'll start at the beginning. So the first thing before giving any chemotherapy, but we're going to talk specifically about ifosfamide, is that the nurse needs to do a thorough pre-assessment before giving any treatment. An important thing to start with is a review of the patient's allergies, so we would understand if there would be any contraindications there. We need to know what the patient's other cancer treatments have been. Have they had treatment previously? What drugs have been used previously? And then are they getting any other concurrent treatment right now that might impact how we would manage any complications? Some specific considerations about ifosfamide is that we would want to review lab work, specifically a CBC to look at counts, and also assessing for kidney and liver function. We would need to double check to see if there was any concern for a urinary tract obstruction. With ifosfamide, hydration is so important, so we need to have an understanding of how the patient is going to be hydrated. Are they able to take oral hydration, or is it going to be done strictly through IV, or a combination of the two? And finally, the last thing we need to assess before starting treatment is the patient's cognitive status, as some neurotoxicities are possible. Before starting the treatment, the nurse needs to review any current medications. So very important to understand what prescription medications they're on, as well as any over-the-counter medications. And St. John's wort, I know, is a very popular one for interactions. And it does have some interactions with ifosfamide, so we would absolutely need to know if the patient has been taking that. And the last step is to review dose calculations. And we understand the importance of the independent second check process, but we want to double check to make sure that the dose of ifosfamide is within the known parameters and appropriate for the patient's diagnosis. As far as the hazardous drug precautions, as you mentioned, ifosfamide is on the NIOSH list, so nurses do need to take precautions when they are administering. Ifosfamide requires some sort of chemotherapy knowledge. It's not a drug that is just going to be handed to a new nurse with no training. So there needs to be some sort of either certification or training through an institution or through ONS to have an understanding of how to appropriately administer chemotherapy. When the nurse is actually administering chemotherapy, we need to take steps to protect our person. So through using personal protective equipment, which ONS guidelines recommend using chemotherapy-approved gowns and double gloving using chemotherapy-rated gloves. In the event that there could be the possibility of inhalation, say you were cleaning a chemotherapy spill of ifosfamide, you would need to wear an N95 respirator. And also, if there's a risk for splash, we would want to use eye or face protection. We want to make sure that closed system transfer devices are used on IV lines to prevent any leakage. And make sure that once the dose is completed, that any waste is appropriately disposed in chemotherapy waste. And the final step in the precautions is safe handling of body fluids. So if a patient is using the toilet. The toilet should be flushed with the lid down or perhaps with a plastic back pad over the toilet. And for anyone that is handling body fluids, we would again want to use the PPE while handling those. Another consideration for nursing is the potential for an infiltration. So if there is an infiltration, ifosfamide is classified as an irritant. So the recommendations for treating that would be applying cold compresses for 15 to 20 minutes, 4 times a day for the first 24 hours after that infiltration. And I'll mention this several times, but ifosfamide is always given with Mesna.
Those are really good things to point out. And again, as we've talked about in most of these episodes, it's so important for the nurse to have that understanding and knowledge about these medications, because there are so many things that are important to be aware of prior to administering, and, to keep our patients safe, as well as, keeping the staff and everyone else safe, during this time. So thanks for going over that so detailed for us. I'm sure that, our listeners will definitely, if this is a new treatment that they're administering, will go back and listen again just to write down some of those things that you need to be aware of prior to administering to your patients. So earlier you mentioned that ifosfamide is used in some other regimens, so in combination. So can you talk about the combination regimens that it would be used in, and does that change any of the considerations for administration and patient management when giving this treatment?
So one of the most common regimens that ifosfamide is used in is the ICE regimen, which is a combination of ifosfamide, carboplatin, and etoposide, given for non-Hodgkin and Hodgkin lymphomas. Something that's different about this regimen is that the concentration of Mesna and ifosfamide is a 1-to-1, and they can be given in the same bag. The dosing for this one is outside the norm. It's given 5 grams per meter square of ifosfamide over 24 hours as a continuous infusion. And since the dose is so much higher, it's given over 24 hours to help to limit toxicity. So it's a single day of ifosfamide. Similar to that is the RICE regimen, which are the same 3 drugs I just mentioned with the addition of rituximab. This is used for CD20 expressing lymphomas like the B-cell lymphomas. This is given as a multiple day infusion, and the dosing for the ifosfamide is much lower. For sarcoma, the AIM regimen, which is adriamycin, ifosfamide, and Mesna, can be dosed as 1.5 milligrams per meter squared up to 3 grams per meter square per day, and it's given over 2 to 5 days. And the purpose of giving multiple days of ifosfamide is to help increase the efficacy of the drug. For testicular cancer, the VIP regimen, which is etoposide, ifosfamide, and cisplatin, is given at 1.2 grams per meter square per day times 5 days. For all of these regimens, the treatments are generally repeated every 3 weeks, but the schedules may need to be adjusted depending on toxicities. They may be delayed. Also, depending on the setting of administration, if it's given inpatient versus outpatient, the Mesna can be given either IV or as an oral tablet.
Definitely, when you're giving it in combination, like all of those that you just talked about, there are going to definitely be a lot of considerations that nurses have to think about with patient management.
Right, not just the ifosfamide, but have to consider the other drugs as well in the regimens.
Does ifosfamide have any black box warnings? And if so, what does that mean for administration or post-administration care?
So the package insert for ifosfamide does not call them black box warnings, but rather box warnings. And there were 4 specific ones listed. The first is myelosuppression, which is experienced in about 30 to 50% of patients, and it can become a dose-limiting toxicity. It may require growth factor support as patients are recovering. They have an expected nadir of about 10 to 14 days. During this time, we need to be really stressing precautions for preventing infection as well as bleeding precautions. The second warning is about CNS toxicities, which are experienced by about 15% of patients. Can range from sleepiness to confusion, hallucinations, all the way to seizures or coma. This is why it's so important before treatment to have a good understanding of what the patient's cognitive baseline is so we can use that for comparison. If it's believed that ifosfamide-related encephalopathy, methylene blue can be given to reverse that toxicity. It's worth mentioning one of the risk factors for CNS toxicities is low albumin. I mentioned earlier the metabolite acrolein, which if acrolein binds to albumin, so if the patient's albumin is low, there's acrolein left that can cause a neurotoxicity. Another risk factor for CNS toxicity is decreased kidney function, so we're looking specifically at the creatinine clearances. And there's also been a few instances where a CNS toxicity has been linked to the use of a aprepitant. So the recommendations that I've found include using other antiemetics besides aprepitant for the first dose of ifosfamide, and we would only add in the aprepitant if the chemo-induced nausea and vomiting was not resolved with use of other antiemetics. The third box warning is nephrotoxicity, and it can actually lead to renal failure. This is an important toxicity to consider when you couple that with urotoxicity. So hemorrhagic cystitis is a very common side effect with ifosfamide, which is why Mesna is always given as a chemoprotectant. The hemorrhagic cystitis is caused again by acrolein, that metabolite that accumulates in the bladder and can cause irritation. One thing to note about Mesna is that it is used to prevent hemorrhagic cystitis, but it is not used to treat hemorrhagic cystitis. The Mesna dosing varies dependent upon the regimen. So some doses of Mesna can be given in the same bag as ifosfamide. Others are given separately. So at the 0 hour, meaning the same time that the ifosfamide starts, a bolus of Mesna is given. Then it can be repeated 4 hours and 8 hours after the start of ifosfamide. The Mesna dose is usually equal 20% of the ifosfamide dose when it's given at that 0, 4, and 8 hour. Mesna can also be given in an oral tablet, and those doses vary a little bit given at the 0 hour, 2 hour, and 6 hours after the start of ifosfamide. If the patient is going to be in an ambulatory setting, it is possible that you could receive the first couple of doses of Mesna, like the 0 and 4 hours intravenously, and then the final dose of oral Mesna could be given at home at the 8 hour. It's important to note that if an oral dose of Mesna is given, the dose is actually double what the IV dosing would be. Patients have noted that the Mesna tablets taste horrible. One of the ingredients in Mesna is sulfur, so they have commented that it has like a rotten egg smell or taste to it. So it's recommended that they take the oral Mesna tablets with a really strong flavored beverage to kind of cancel out that taste. The Mesna tablets are also very expensive, surprisingly, so it may be more cost effective for the patient to receive the Mesna IV. If they are taking oral Mesna and the dose is thrown up, like within 2 hours of taking it and it's vomited, the patient should contact their provider to see if they should take another dose when it's needed. And the last thing about hemorrhagic cystitis is that hydration is so very important to preventing hemorrhagic cystitis. So it's recommended that patients take at least 2 liters of hydration per day, either intravenous fluids or oral, or it can be a combination if they're able to drink.
Thank you for going over all of those for us. You mentioned right at the beginning, that this treatment was, developed by the same company who did cyclophosphamide. And I can remember, patients having to have 3-way Foley's and bladder irrigation because of that, because of the hemorrhagic cystitis that they would get. And just how, you're talking about with ifosfamide, the importance of the Mesna and the hydration, that just cannot be reiterated to patients too much, because that's so very important with that potential adverse event. So what are some other common adverse events that nurses should be aware of?
I kind of talk about it in the scope of adverse events and side effects, both that nurses need to be aware of. So ifosfamide is classified as moderately emetogenic. So we want to proactively manage chemo-induced nausea and vomiting. It's reported in about 50% of patients. So we would want to make sure that they know what that they have antiemetics and that they know how to take them properly to prevent it. Another really common question for patients that are receiving chemotherapy is they always want to know if they're going to lose their hair. And about 90% of patients receiving ifosfamide experience some degree of alopecia. So we want to make sure that they're informed of that. Some other potential toxicities include cardiotoxicities. So patients could develop arrhythmias or EKG changes. So we want to assess for cardiac risk prior to starting treatment. And the last important one I'll mention is pulmonary toxicities. And again, we need to assess frequently for any concerning respiratory symptoms. So patients have the potential to develop interstitial pneumonitis or pulmonary fibrosis as a result of treatment.
Thank you for going over those as well. Again, some really serious ones that really need to be considered and thought about. And just that monitoring and what kinds of things you're going to need to look for after the fact, with these patients. So, ONS does have communities where members will post questions that they have. And we found a discussion that actually involved ifosfamide, and they were discussing tools to monitor and manage ifosfamide toxicity. Can you talk about some of the tools that oncology nurses can use?
So for the CNS toxicities, tools and assessments kind of depend on the setting where the patients are. So if it's given in an outpatient setting, patients are not going to be monitored as frequently for neurotoxicities, but we would want to do a neurocheck before any treatment's given, looking specifically at the patient's level of consciousness, if they've had any changes in mood or behavior, in their orientation, if they or a family member has noticed any changes in their speech or language. Another really important thing to note is voiding characteristics. So are they urinating like they normally would? That could be indicative of development of hemorrhagic cystitis and some issues related to that. And then also understanding sensation in their extremities. So those are all things that we would want to look at before we give each day's dose. Now, my institution uses Epic, and we do not have anything specific for doing ifosfamide neurochecks. It's something that I really want to go back and request that we have added. The inpatient setting is going to do a very similar neurocheck, but they're going to be doing it more frequently. It's recommended to do every 4 hours. So those neurochecks are going to depend on the setting. Some other things that we would want to monitor closely are kidney function. That could be a warning sign of nephrotoxicity. And then neurotoxicity. So we're going to prophylactically treat for hemorrhagic cystitis by using Mesna and also monitoring for hematuria.
Thank you for pointing those out. I think that, our listeners will really appreciate hearing those things. And like you said, that your Epic doesn't currently have the neurotoxicities in your system, but is a really good place to have that, because then it also prompts the nurse to remember to make sure that she's doing that as well.
And also to be able to go back and compare from previous days. That's the awesome piece of the EMR.
Yeah, that's very true. Especially, when staff are switching out every day or even shift wise, that is really good to be able to go back and look at that and have it right there. So I wanted to ask you, what are some key education points for patients receiving ifosfamide?
Sure. The first one I cannot stress enough is the importance of hydration. So we're going to teach patients hydrate, and even if you think you've hydrated enough, hydrate some more. One thing to note, we do not want patients to consume any grapefruit products that can impact the way that the drug is metabolized. So they should avoid grapefruit juice or eating grapefruit. Don't let your guard down when talking about preventing infection. So this is probably a time that the patients are going to want to avoid crowds or being around anyone who doesn't feel well. They also need to take precautions to prevent bleeding. So that might be using a soft toothbrush or an electric razor. Next, wash your hands, wash your hands, wash your hands. So very important in preventing infection. Patients need to make sure that they're updating their team with any medications that they're taking, even if it's over-the-counter meds. Sometimes patients will start a treatment and they'll have a medication list, and then a few months or a few weeks into treatment, they decide that they want to add in a supplement that they read about. So we need to be regularly asking patients to update their med list and make sure that they're not taking something that's going to counteract the chemotherapy. Patients need to know that they need to take their nausea medications for the first few days, even if they don't feel nauseous. It's good to keep those on board to prevent it. Prevention is so much easier than getting it under control. Once that horse has left the barn, it's sometimes difficult to get that under control. We're going to encourage eating small, frequent meals. That can sometimes help with staving off the nausea and vomiting. Alcoholic beverages should be avoided. If the patient does want to consume alcohol, they really should talk with their physician before doing that. It's also important to get lots of rest and make sure that the foods they are eating are nutritious. And finally, understanding that chemotherapy treatment can make patients feel very fatigued and drowsy and dizzy. So they should take caution when they're driving or if they're going to be doing any tasks that require them to be fully alert, like driving a tractor.
Thank you. Patient education is so very important, and knowing about the treatments that we're administering is, just key. And then being able to translate those important key educational points to the patients and family members so that they understand that is just an important part for nurses to know.
Yes.
I just want to thank you, Rebekah, for being with us today. You've given us so much information about this treatment that is used very frequently. And to end us off, I have 3 questions that I like to end our episodes with, and we'll just go through those really quickly. But the first one is, what are some common misconceptions about ifosfamide?
I wouldn't necessarily call this one a misconception, but it could be misunderstood. So ifosfamide and cyclophosphamide are very similar in their structure, but it should be noted that the dosing is very different. So ifosfamide dosing, because of its slow uptake, is generally 4 times greater than that of cyclophosphamide. So just keeping those 2 drugs straight is really important.
Next question. What's something about ifosfamide infusions that's not often discussed, but you wish people knew more about?
Family planning. So for patients that are on ifosfamide, it is not recommended for them to become pregnant while on ifosfamide. The ability to get pregnant after treatment depends on the dose and the duration of their therapy, as well as their initial diagnosis. So GYN cancers, depending on the extent of their surgery, may inhibit their ability to get pregnant following treatment. And patients should not plan to father any children while on ifosfamide and then for the 6 months following end of therapy. But it is not unusual for patients years later to have children.
Great. And then finally, what are some resources about ifosfamide for both patients and providers that you can recommend?
So for patients, I would recommend using chemocare.com that can be used for searching for specific drugs, so they could look up ifosfamide. Cancer.org allows searching by disease, and it could list possible treatment scenarios. NCCN.org has webinars for patients that are set up by disease, and it also discusses different treatment plans and options. And then finally, institutional education. So I know our institution does some one-on-one education with patients prior to starting their chemotherapy. So that's a great opportunity to share resources with patients. For providers, the package insert for ifosfamide is very informative. There's also lots of literature about managing side effects for the various toxicities from ifosfamide. And there's also results from ongoing clinical trials involving ifosfamide. And the last thing I would recommend for providers is using the NCCN guidelines that, again, are set up by disease.
Well, Rebekah, thank you so much. Again, you have given us so much information about the administration of ifosfamide and things that our listeners will be able to use in their care of their patients who are receiving this treatment. So thanks for joining us today.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.